Thank you very much for the presentation. Thank you very much, every one of you, that you are here in Athens this year. We'll speak about the augmentation of the classic back repair. These are my disclosures. So if we speak for anterior shoulder stability, we have this as the more common scenario. And we have definite answer for the green ones, but for the red one, there are a huge controversy. But these are the most cases that we confront. And these are the prognostic factors for recurrence. There are patient-related factors. There are previous operation, which is a different topic. And the most important factor for decision-making for the surgeon is the bone defects, as we previous here. The most popular options is to repair the Bankart lesion and to augment the bony surface. And actually, as you hear earlier, there is a gray zone between this, between the definite indication for doing a bony procedure or for and the no bone loss for doing Bankart repair. Many surgeons extend the indication of the classic Bankart repair, and they calculate more the lower complication rate that they have with this operation. But many surgeons lower the indication for bony procedures, and they do letter Z, expecting lower recurrence rate. So we start from the beginning. The essential lesion is the Bankart lesion, and the first is to restore the Bankart lesion. So the goals of the operation are referred earlier. We should perform technically a good Bankart repair, but even this, the literature says that there is a high recurrence rate, which is not acceptable. And considering the prognostic factors, as we said before, there are categories, but the surgeon can handle during the surgery the bone defects. And we know that bone defects change our results, and we know that bone defects, there are everywhere, even for the first time dislocation. And there are many studies that they show that a little cases has no bone defect, and more fancy studies with 3D CT shows that in every case there is at least a minimal bone defect, either from the glenoid side, either from the humeral side. And we have the numbers, the 25% of the lower diameter, anteroposterior diameter of the glenoid, which is a definite indication for doing bony procedure, and the subclavicular size, 30.5% from this defect and more, we have low inferior results. And from the humeral sides, we have Hill-Sachs lesion, but there is controversy for calculating this. And we have the concept of non-engaging and engaging Hill-Sachs lesion, and the concept of the glenoid tract, and the prediction for on-track or off-track lesion before the surgery, that every of these concepts shows that the combination of lesion counts and not consider its lesion separately. So which is the limit to change our indication from soft tissue procedure to a bony procedure? Because as I mentioned before, there is a gray zone between the absolute indication for the procedures. And this is the gray zone. We should augment the classic Bankart repair with another soft tissue procedure. And we gather all the procedures that they are referred in the literature, or at least the most popular in an article, and they all have the same goal, to restore the volume of the anterior or the posterior capsule. And we have posteriorly remplissage and anteriorly ASA and DAS, and also we have the combination as you listened earlier. And Remplissage tries to push head back and protect the anterior structures. ASA tries to push the head back, but and both are non-anatomic, and they offer dynamic stabilization. And of course, there are supplementing procedures. They are not standalone procedures. And the remplissage, we start with the capsule in the left, and we try to shrink in the right. This is the final and the initial. I don't have the mouse pad. Okay, the technique. We put the anchor. We used to put one anchor. Most of the cases we put two anchors, and we pass the suture from the infraspinatus and the posterior capsule. And then we close the gap as we see in that picture. And our long-term results, 8 years after the operation, in 65 patients, we have published these results. We have a recurrence rate 5.6%, highly patient satisfaction, and 70% they return to sports. We haven't noticed any serious restrictions in range of motion. And we have the ASA that Marco Maiotti already mentioned of this, and he had presented in previous shoulder course. We do this technique, but we use the knee knot, and we perform it in this way, in this fashion. We pass the sutures and we do a loop, and then we use this knot to I get it. It's a very strong knot. I advise you to try it. Our experience, we expect the publication in a few weeks. We have recurrence rate 8.8%, and also we don't have any serious deficient, clinical significant deficient in the range of motion. And there are many studies that they show that there is a low recurrence rate with these procedures, the soft tissue procedures, non to minimal motion loss, and very low complication rate. And based on remplissage, because there are more data than the other procedures, the complication rate is 0.4%, comparing with bony procedures, which is almost 15%. So always there is a point that we should do and should augment the glenoid bony surface and go for bony procedure. And I think that the augmentation of classic back and repair, this is the position for me, and my clinical practice is between the no bone defect, between the subclavicle bone defect. Apart from the glenoid defect, we should consider also the other factors for decision making. Earlier, we have a discussion with thrown athletes and contact arteries, and the proposal of the speakers was doing simple back and repair, which is paradox because we augment the back and repair, we do bony procedures, and in order to have lower recurrence rate. And in this patients group that they are more prone to recurrence, we say that we need something less, probably because of their demands or because of our techniques. So the final conclusion is that we lower the recurrence rate from the simple arthroscopic back and repair from 30% in 10 years to 5.6% in our case, 5 to 13% in gathering the literature, summarizing the literature. Always respect the indication, So a 25 years old recreational tennis player with 3 recurrences and glenoid bone loss lower than 10% is a good candidate for soft tissue augmentation, but a 18 years old competitive handball player with over 20 recurrences and glenoid bone loss over 10% is a bad candidate for a soft tissue procedure and should go for bony procedure. So we should know and use this procedure with proper indication. We have good long-term results for emblissage. We expect the same for ASA and DAS, but we have short and mid-term outcomes, but they are very promising. We should avoid overtreatment with bony procedures and always respect the indication. If you like all this, you should be a member of ESCA and especially ESA. I invite you to submit your articles in the Journal of Physicos, and also don't underestimate and don't forget the national societies. It's a privilege to be a member of this. So I would like to thank my mentor, Dr. Brilakis. I would like to thank my supporting team inside the surgery and outside this, and you for your attention. Thank you very much.